Wow. I've been scribbling. Now I just have to be able to read what I wrote. Thank you very, very much to the panelists for your wonderful presentations. We have now about 25, 30 minutes before lunch for some questions. And I thought, if it's okay, I'd start with one question, if I can read my writing here. So, as we were listening to the presentations, Jennifer, you mentioned which I never honestly thought of, the lack of a defined role for family caregivers. So within that lens, how can we, or what would your suggestions be in developing additional strategies to be more inclusive of family caregivers? Of course, keeping in mind and being respectful of patient preferences. And then I would also challenge Stephen to address that same question kind of from a language and cultural lens, or when there's discordance, I should say, in language and culture, and then Nora from more of that community perspective. So, Jennifer?
Sure, so thank you for your question. The issue of having a role in care delivery is really a challenge. You mentioned nomenclature. That's, I think, I know you posed the question to Stephen, but I'd like to sort of address that we often refer to family caregivers as family caregivers, but people who are providing care often don't identify with that term. And so I think the language here is very difficult because for many people, it's just that's what you do if you're a spouse or you're an adult child. And, so how we sort of identify what are the roles and sort of what's the trigger that moves someone into a more normative role to a caregiving role is a challenge. And often, when we think about the specific activities that families are involved with, it's not always for health and function disability reasons. The literacy is a challenge, or the ability to speak English. So often families are serving as translators. They're recording notes. They're sort of a walking medical record often for patients in being able to provide information that's necessary in terms of providing good quality care. So I think the issue of role really will vary depending on the patient population, the setting. I think one strategy in my own work has been to focus on developing simple strategies that are feasible to implement in care delivery, approaches that focus on empowering patients and families to have these kinds of discussions themselves, to clarify what help the patient would like, I think is very important in terms of respecting the fact that this is the patient really is the person who's receiving care and should be the sort of the driver of sort of establishing what role the family should play. But I think that care providers, clinicians, also need to be sort of looped in and respect that when patients rely on a family member, that family member is part of the discussion. And that can be complex. I do think that as we move towards the diffusion of consumer-oriented health information and potentially being able to leverage the use of the patient portal and provide families their own identity credentials according to patients' preferences, that is a strategy that can sort of trigger to the clinician that if the patient has engaged a family in this capacity, that this is likely someone who the patient would like to be involved in their care. And it's okay that this family member should be able to access lab results and be able to send direct messages. Thank
you. Yes. Oh, thank you. Excellent suggestions.
So, how do we define family? In the neighborhoods I live in, it's not all related to blood. And so the dynamic in these settings, hospital settings where there are legal issues and we have patient autonomy, they don't like that. Who is this outside person? Unless you're going to help focus on compliance. Other than that, no pushback. You understand what I'm trying to say? Yes. So I think that the solution is getting... What did the physician say in the barbershop? We don't get this in medical school. We have 1 week, and we call this social medicine. That's it. So I think that's where we begin. Because when they left that place, they realized why they became a health professional. That's what we have to get back to. Get the care back in the caregiving.
In terms of the community, as I mentioned, one of the biggest initiatives I'm working on is trying to bring together the community-based organizations with healthcare sector. And it's a challenge. You know, all the money is in the healthcare sector, and as they have become aware more about, you know, social determinants of health has become the new thing that everybody wants to work on, the medical community wants to recreate everything and build their own and not work in the communities that already exist, many of them being, you know, trusted community partners that people know and have worked with for a long time that have been working on a shoestring budget. I can't tell you how many like contracts we've helped, and they just give them $50,000 to fund an FTE, and they're over the moon about this. I mean, it doesn't take much, but then they can dedicate a person who can do some of this care coordination, who can do some of this follow-up there. So I think that there are a lot of opportunities for folks to learn more about community-based organizations that exist and that can be helpful and are chronically underfunded, that they can work with the medical community and not medicalize it either. That's the thing coming, you know, as a social worker's daughter, I think too of that risk of really recognizing the difference between what social workers do and medical professionals. One example, again, with the GWEP program in Seattle, in the Washington area, where they've actually had area agency on agency representatives that have been funded to go to doctors' offices for patient-centered primary care homes and work with them almost like a pharmacy rep, like, let me tell you what we do, what we can do for you, what we can provide, and recognizing that the way they've been using their RNs and their practices really is not the RN's expertise to figure out transportation or meals. That's more a social worker's expertise. So recognizing what both parties can bring to the table and allow them to practice at their highest level and work in the community, I think is really one of the successes that we'll have in addressing the aging population.
Thank you very much for that. I'm going to go to, just because we have about 20 minutes, I'm going to go to the members of the roundtable. Winston, I think I saw yours up first. Your card.
Thank you for a very stimulating panel. I'm Winston Wong. I'm part of the Roundtable Committee as well as part of Kaiser Permanente. So I do want to venture into a territory that none of you discussed directly, but I think I'd be very interested in getting your perception. And that is around the promise or detriment with regards to introducing telehealth into interactions with seniors, and what you would see as the prospects of leveraging this new technology or emerging technology, and or warnings that you would give healthcare systems in terms of not doing this very effectively, given all the points that you raised with regards to addressing community needs, addressing caretakers, et cetera.
Well, I can go first. It's a great question. And I think one we think about a lot. I think there's a lot of promise in telehealth. You know, when I was at the White House, they were very enamored of Silicon Valley and would send me out there all the time, and people would talk about these apps that I was like, have you ever interacted with a frail elder? So that was not, that can often be a disconnect, but I think, for example, Lyft and Uber are very active in trying to get engaged and getting people to medical appointments, but talking with people there, you know, about how could we design the app that older people can actually use it, that it's easier, that it's not so confusing. So, you know, having products that are more focused on the users. I think one example I'll leave you with that really had an impact on me was a program where when people were discharged, they would give them an iPad that had already been set up, and this was to help reduce readmissions, assign them to a nurse professional that they could interact with on, to see how they were doing on follow-up. Now, what they found was a lot of older people don't want people in their homes. And you think about it, like, especially if you've just been discharged from the hospital, you've been sick, people are proud of their homes. They think it's a mess. I don't want this person in here. I don't really know this person. So they would give people the iPads, and they had the power to set it up the way they wanted, to put it in a place where you could only see the clean room, and interact with nurse professionals that, looked like them, spoke like them, could communicate with them, and had much better outcomes because of that ability to use the technology and bring it into the home. So I think things like that hold real promise.
So I would say that we can't let technology be a cop-out. High tech works after high touch, and that the real promise is not portals. I'm only saying this because we have them and people aren't using them. We don't have the uptake that people had expected. But that the miniaturization of diagnostic tools is the key. A doctor, physician, they no longer need to be tethered to a hospital or a clinic. The diagnostics are very sophisticated. You can do an echocardiogram with the size of your iPad or laptop. Electronic stethoscopes. So we can unleash them from the hospitals and the clinics. They're there because it's convenient. And we have to deal with shame. We've seen the same thing. An entire program where you'll get community health workers coming to your home, and they say no. Why? You're going to judge me. That's where we have to work. Why are we judging people because they're poor? They won't let you in their house. They don't trust you.
So I think I would just echo some of the comments that have been made in terms of the potential promise of telehealth, but the importance of sort of recognizing the preferences and the capacity of older adults, and making sure that whatever strategies are really used to leverage existing resources and potentially be able to, get a geriatric psychiatrist consult that wouldn't otherwise be possible because someone's homebound or can't, be transported, and to really also attend to some of the specific needs of the population who may rely on a family member, so that the care is really wrapping around individuals where they are. So I think it has a lot of promise, but also requires thoughtful attention to developing it in a way that really extends and improves quality of care and efficiency of care.
Can I say one more thing? Well, when we talk about this in the context of saving money, I think that's the other problem. Because it's not talked about in terms of telehealth as a way of, when I hear the argument, it's about how much money we save. That diminishes its power. We come out with drugs that can cost thousands of dollars a pill, and nobody's blinking an eye in terms of changing that system. So if telehealth costs more and delivered quality, we should embrace it. But all the arguments when I'm in rooms like this is, look how much money we save by using the computer instead of a human. That diminishes the other person on the other end.
Okay. I think, Michael, I think you had a question.
Hi, my name is Michael McKee. I'm at University of Michigan. I'm one of the new Roundtable members here. So I wanted to thank everyone for their wonderful presentations. So I wanted to just highlight an angle that often is not on the forefront of our attention is people with disabilities. I know there's been a couple points that were brought up. I think you mentioned about hearing, vision, cognitive decline. And then Nora, you mentioned about some of the barriers, somebody with mobility issues. So it's important to recognize that 1 in 5 people have some form of a disability, yet it's often sort of the trailing end when we think about equity, inclusion, diversity. So I wanted to just see if you guys could elaborate, if there were any other areas of findings on how it actually impacted your findings, and what are proposed solutions that from your work in the communities and also your institutions if you could just highlight some of that, that'd be great. Thanks.
Nora, you want to start?
Sure. I would just mention, from my own education, this is another area like similar to healthcare and social services that don't really understand each other. The aging and disability communities don't really understand each other. And, when the Administration for Community Living became the Administration Community Living, they brought together all these disability organizations and the aging organizations. And it's been an arranged marriage that can be uncomfortable at times. And we're doing that at our institute. And I would say, we continue to learn a lot from our colleagues in the disability community about many of their challenges and approaches to solutions that are different than the aging community has typically addressed that. I think it's similar to what Dr. Thomas was saying, about some of the people in the disability community are still very advocacy oriented, which is, because they've been mistreated over the years, or people don't acknowledge what they bring to the table. And so often when we're talking about, let's partner with healthcare, again, there's total distrust of the healthcare community. And partner with healthcare? Are you kidding me? And so, I would just say we continue to learn, but we have a long way to go. I think that just even bringing together these two communities has been a challenge.
So thank you for your question, and I agree with Nora that the communities are very different in terms of thinking about individuals who are living with disabilities, who are sort of more working age adults, and who have sort of grown up and living their lives with expectations of integration and work, as opposed to older adults who are experiencing age-related impairments, where typically they are less. They seek to be less actively engaged in driving their care. There's variability, certainly, but they tend to be a little more passive in interacting with the medical community, and they tend to be less interested in sort of consumer-oriented, consumer-directed care. I think your comment raises the challenges that the people are living with disabilities, but these disabilities are highly varied in terms of whether you have a physical impairment that may make it difficult to get on the exam table versus hearing impairment that may make it more difficult to communicate verbally with medical providers versus a visual impairment that may make it impossible to go on the Medicare website and pick a health plan. And so sort of thinking about what are the specific challenges for each of those populations in developing strategies is highly complex, but incredibly important in terms of thinking about how we go about developing effective strategies to really allow everyone to participate in their care to the extent that they can.
Thank you. I'm going to just quickly go through. We have a lot of cards up, so we have 10 minutes. I'm sorry, I can't see your name card, but you're next. Thank you.
My name is Yinka Chiambala. I'm at the University of Wisconsin-Madison School of Pharmacy and also one of the new members of the Roundtable. First of all, I wanted to thank you, Dr. Thomas, for the sort of highlighting the role of the pharmacist. What you talked about, bring a loved one to the doctor, for example, and as you mentioned, a lot of communities of color don't even know they don't have an understanding of how do I just get to the doctor, for example, and then the pharmacist being able to come to the barbering salon to actually meet with these people. One of the things I wanted to sort of bring to the forefront also is some of the work that we have done is that there is a lot of misperception of illnesses, where we see that a lot of people don't understand their medications, they don't understand why it's necessary, and also that shows that the pharmacist is also important to talk to these people and come to the salons. But one of the things that we've seen is that there is a lot of focus on education versus health literacy in communities of color. And I'm just wondering, do you have an understanding of why is there a lot of focus on that, even though we know from research that education is not directly related to health literacy? And it seems like a lot of people believe that that is the solution to dealing with a lot of confusions about medicines, a lot of confusions about health information. And so I just wondering if you had any perspective on that and other people can chime in too. Thank you.
the pharmacist that we interacted with said something that has stuck with me. We are more than distributors of pills. That's what they said to me. We are full-fledged health professionals. And so in the hierarchy of all the medical, they felt marginalized. And so what you saw was a scene there from what was a community-based pharmacy component in that particular school of pharmacy. And in those settings, we would actually have the equivalent of a brown bag day. Bring your loved one's medication to the barbershop. Pharmacists will be here and walk you through it. And you know what? I'm not talking about little lunch bags like I had. I'm talking about grocery bags that people would come to the barbershop with, 20 plus medications. Highly, highly complicated. But the pharmacists, I don't even know how they do the billing and all that. That's a different issue. They were committed to their pharmacists being full-fledged health professionals and training them to talk and meet people where they were. That's why they love the barbershop setting. So I think that, some say the glass is half full. We've made progress. Some say it's half empty. You saw me showing some of the half empty. I think the glass is the wrong size. I think we need to reimagine what it is that we call this glass and really begin to think out of the box and very creatively. So it is not just, see, my problem is that all these things go back to educate the patient or educate the community. There's something wrong with the community. I think there's something wrong with our systems. And that's where we have the best leverage to make a difference.
Thank you. Kim?
So thank you to the panel, and thank you, Dr. Thomas, for setting my comments up. and I want to talk to Jennifer and go back to your discussions around and information around decision making. And I'm really thinking a lot about that and sort of a chicken and an egg thing here with complexity and decision making. So from our first consumer this morning, Mary Ann talked about looking for the answer that she already had, right? So confirming her decision making is what I heard there, right? Or maybe you helped me connect that. Was that what was going on for her? So did that, by confirming her choice of something or her knowledge of something, did that eliminate future decision making for her, or did it eliminate the thought that she might have another decision around that piece of her care that she was thinking about? And so it made me think about another consumer I know, and that is faced, and all consumers that are faced with many decisions outside of those around their health, right? So, and the complexity of that as we age, right? Being able to make those decisions. So I'll talk briefly about this other consumer, and that consumer is my mom, and many of the people on the roundtable know her. And knows that she's probably never felt the need for advice when it comes to decision making of others, nor would she have followed it if she was given some of that advice. But she just recently retired this year at the age of 73, and what drove her retirement decision was decision making. So she sold property and casualty health, and she was concerned about her decision making ability of working with her clients in terms of being able to guide them through their decision-making process and present what they needed to know in order to make appropriate decisions about their insurance, in this case, property and casualty, but of course that probably translates to health as well, right? And even now, as she is downsizing, she regularly comments to me about all the decisions that are required for her to make. And I've been confused about this, what she talks about as decision making, because it's cleaning out a closet in her utility room. So what decisions are there in that, right? In my mind, that's not a decision. You need it or you don't, right? But she's she's kind of overwhelmed by this. I know even now, as you go to a restaurant, right, she'll ask, what are you having? What do you like, right? And maybe she'll just order what I'm ordering because now I don't have to make a decision. So some may think, oh, she's on the road to cognitive decline, et cetera. Well, no, I don't think that's what's going on here yet. I just think about this complexity of decision-making in her everyday life as a consumer and aging, and now as she and others move into health events, right, then the even more challenges and more decision-making that they're faced with. So it's making me thinking about the level of the complexity of the system being a factor in that health decline simply because of the overwhelming amount of decisions is that, helping feed that decline. So.
Thank you for those thoughts. I think we have time for, if it's promised to be brief, Ernestine, do you have a comment or a question?
I think Dr. Thomas can probably address my question, and it should be as short or as long as you want to make it. Ernestine Willis, I'm a Roundtable member as well as a faculty at the Medical College of Wisconsin, and I appreciate the tone of discussing don't blame the client or the patient or the consumer, sort of deal with the systems and how complex the systems are, changing the system. So my question to you, Dr. Thomas, as you talk about the HARE program initiative, your model that you have developed, have you studied it enough to know whether or not you are precipitating institutional change? That's the first part of my question. And the next part of my question is, have you considered applying it into independent living environments? That's a two-part.
So it's no on the independent living, but there's all upside from where I am in these humble settings. In many ways, we've been doing it on a shoestring. And I told my colleagues at Cigna that it was charity because it came from the foundation side, and they got mad at me because they said, no, this is part of the core values of our corporation. I said, I like that, but we need venture capital. We need that level of investment. So what's interesting is I heard my colleague here, Dr. Wolf, describe the audio tapes that they do of the patient interaction in the hospital setting. I would submit to you that the doctors talk differently in the barbershop. Automatically, not prompted. They get the plain language real quick. They're nervous because they've not been in these settings. Now they can feel what the patient feels like when they come into the, you know what I mean? There's a certain amount of empathy that happens. So there's where we got to get back to. And so we need to get our providers in settings where they can reconnect with empathy. And then the other things almost take care of themselves. Because if the patient begins to ask you the right question, you have a way of answering. And guess what? Everybody in the shop's listening. So you're doing a community education all at the same time. We're looking for the kind of investment that can take it to the next level. And those come from the corporate side of wherever the companies are here. Your foundations are great, but it comes from that corporate side. And this is where, as academics, we have trouble thinking about, well, what's that business model? What's that look like? Return on investment. We don't even like those terms. Those of us in public health, we give it away. So if we're going to stay in the system we have, which this administration is making clear in a year, we're going to try, which means we're going backwards a little bit. How do we sustain the gains that we've made through the Affordable Care Act and other kinds of initiatives in the face of an assault? And that's why in rooms like this, we need to argue more with each other. Let's assume we're the choir, but most good choirs practice. And so when we leave these rooms and we go back to our more hostile settings, I get like tongue-tied trying to push back against the effort to get back to fee-for-service, et cetera, et cetera. So Maryland does help. We have global budgets in Maryland. So one of the big hospital systems here actually uses their outreach in the barbershop as compliance with their community benefit requirements. And they're collecting data and they're tracking people. The problem I have, because I open the doors, I create the space for them to do that, is they walk away with all the data. They walk away with all the data. And then they use HIPAA to say, oh, I can't show it to you. I got a problem with that, because now I have not the evidence to demonstrate that this works. This month, New England Journal of Medicine, randomized clinical trial on hypertension control in black barbershops. Highly, highly successful. So what was in the margins is coming to the mainstream. Ernestine, we just need to make sure that as they rush to these humble places, they don't destroy the very unique setting. There is no black hair cutlery or supercuts or any franchise. They are all mom and pop operations where social norms are set. It is the place where we can make change.
Thank you very much. Well, I think our time is up. I'm being approached. So thank you to the panelists. Thank you to the interpreters, and apologies to those questions that we weren't able to get to.